Good evening, everyone. Welcome to second session of our Karnataka Neurosciences webinar series. It's a new initiative, so the idea is to all cities of Bangalore, cities of Karnataka to share their experiences, case or whatever this one. So this is second. We really thank Hubli team for accepting this one and presenting today. For today's session, we have two eminent persons as a chairperson. One, Professor Dr. Saroja Madam from Belgaum. She is a professor and HOD of neurology at GNMC. Welcome you, ma'am. Hello, ma'am.
Thank you.
So another eminent person, neurosurgery from Shumaga, Panaji. I think he is able to join us. So we also invite him and thank the Dr. Saroja and Panji for accepting this to chair this session. We will start the session. We have four interesting cases, two from neurology and two from neurosurgery. What we thought, we will alternate. Once Dr. Dr. Datta will Nadigar will present, followed by Dr. Suresh Dukhani will present, then followed by Bhushan, followed by Dr. Anirudh. So that is how the flow will go on. So I'll be here to moderate. I think Dr. Saroja Madam can take over the proceedings.
Thank you so much, Dr. Raghunandan and Dr. Guru Prasad. It's a very good initiative, and that's why we need young people in Karnataka Neurosciences Academy. And for there is Dr. Datta. May I?
Not audible.
Very well. Been meeting every.
Hello, I think we lost Madam.
KNA. So
we are not. Your voice is breaking. You're not able to hear it.
Patient.
I think some net issue is there, madam. We are your voice is breaking in between.
Okay.
Yeah, I think Datta, we can start.
Yeah, we can start. Datta Nadigar, sir. You please start, sir.
Yeah. Let me share my screen first. Okay. Good evening, everyone. Are my slides are visible and am I audible?
Yes, sir. Slides are visible.
Visible and audible. Go ahead, sir.
Okay, fine. Thank you, Karnataka Neuroscience Academy, for giving Hubli Dharwad a chance to present interesting cases. And first case I'll be presenting an interesting case of twitching muscles and hallucinating brain. Let me start straight away. We have seen on patient on 23rd March 2019, a 32-year-old male, teacher by occupation, and with a 3 weeks history of diffuse body ache, predominantly low back and lower limbs. And he also gave history of mild malaise and the fever prior to the onset of these symptoms. He also noticed involuntary tremulous movements of toes and fingers, along with flickering movements in thigh and calf muscles, almost continuously throughout the day. He was seen by a physician earlier and underwent basic routine investigation MRI of the spine in view of his backache, which was unremarkable. He was treated with symptomatic medications by earlier physician without much relief. With this background, he was seen by us on 23rd March 2019. Going further into the history, he denied any weakness, sphincter symptoms, sensory symptoms, or lower cranial nerve symptoms. He also denied any behavioral symptoms, but mentioned a couple of short-lasting episodes of nocturnal confusion, from which he has improved spontaneously. His general examination, higher mental examinations, cranial nerve examinations, and motor system was unremarkable, with hypoactive DTR and abnormal involuntary movements. These are the involuntary movements which are seen. In the left thigh, flickering myocardial discharges. Here in the left calf. And the toes.
वो कलवा चलता सर उसका मतलब वो गोली लेने के बाद चलता है ना कैसा चलता है
हाथ आराम से रखो। He was admitted for observation and investigations. His routine investigation, including hematology, blood biochemistry, was normal, except mildly increased thyroid stimulating hormone and raised CPK. He had already undergone spine MRI for backache, which was normal. However, brain MRI was not done earlier. This is a SAS section of this cord screening, which is unremarkable. He underwent EMG studies in view of his involuntary movements, and his nerve conduction study was normal. EMG showed. Can you hear?
How it is heard, sir? Well,
EMG showed a myocardial discharges consisting of irregular triplets and multiplets. Between the burst, there was electrocerebral silence, suggesting a myokymia. However, there was no myocardial discharges. With this, during the hospital stay, he developed abnormal hallucinatory behavior. After 2 days of hospitalization, third day, he started developing this abnormal behavior.
सर हाँ बस 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 हाँ क्या हुआ
Are you able to hear?
जी बताओ, जीप दिखाओ। हाँ, हाथ ऊपर उठाओ, हाथ।
आंखें खोलो कुछ नहीं आता
Considering his clinical findings, imaging features, EMG findings of peripheral nerve hyperexcitability, his VJKC antibodies were sent and he was started on Finitan for symptomatic relief. Meantime, he developed insomnia, hallucinatory behavior, for which he underwent MRI brain and CSF, which was unremarkable except for the few white hyperintense lesions in the parietal occipital area. However, his blood pressure was normal. So his CSF was also normal. And then came his Casper antibody, strongly positive. So in view of this findings of peripheral nerve hyperexcitability, CNS features, and Casper2 positive, we thought of Mormon syndrome, and he was put on IV methylprednisolone 1 gram per day. He was given 5 cycles of Plex, to which he responded very well. HRCT chest done to rule out thymoma, which was also normal, and he recovered completely after Plex and was discharged with oral steroid with a plan to taper slowly.
हो गया, वापस। Turn on. Okay. हाँ, बाओ वापस बाओ। Come. How are you?
I'm fine, sir.
Okay, great.
10 days after discharge, he was presented again with severe pain in the both lower limbs, which was disturbing his sleep. Examination was unremarkable except hypoactive DTR and nerve conduction showing mild reduction in snaps. Diagnosis of neuropathic pain appearing late in the clinical course was considered, and he was prescribed pregabalin with a small dose of clonazepam, to which he responded well. So this case was consistent with the standard description of Morvan syndrome with few differences. The differences to highlight are usually Morvan syndrome affecting little elderly. Our case was younger, he's on 32 years old. Our case was progressed little faster than the standard description of the syndrome and developed symptoms within 1 month of initial symptoms. There is a higher incidence of cerebral ataxia in literature, around 35 to 40% in various studies. But in our case, he did not have any cerebral symptoms, and he developed neuropathic pain during recovery after immunotherapy. Thymoma is reported in about 40% cases of Morvan syndrome, Our case of MOR1 did not have thymoma in the initial investigation. Most patients will respond to immunotherapy and 25% will have relapses. Our case had no relapse during initial and long-term follow-up. That is, we have a follow-up of 1 year, and he did not have any recurrence of symptoms. However, he developed neuropathic pain after plex. So, coming to the standard description of MOR1 syndrome, it's a rare constellation of neurological symptoms consisting of peripheral nerve hyperexcitability, autonomic instability, and encephalopathy, often associated with antibodies to VGKC. Usually male-dominated entity, 19:1. Insomnia, hyperhidrosis, dysautonomia, neuromyotonia, or myoclonus were consistent findings and were seen in about 100% patients. Hallucination can be seen in about 75% of the patients, and more than 45 to 50% will show Casper antibody positive. But the very important feature to differentiate between limbic encephalitis is a conspicuous absence of seizures and benign MRI in patients with MOR1 syndrome. In contrast to limbic encephalitis, where seizures and temporal abnormalities on MRI are usually classical. These antibodies cause neuronal hyperexcitability by suppressing the voltage-gated potassium channels, and it actually suppresses the potassium outward currents needed for a repolarization of motor nerve. And the various combination of Casper2 antibody binding in MOR1 syndrome could contribute to distinctive multifocal phenotype, because this antigen is expressed in various structures in the central nervous system as well as the peripheral nervous system. Other associations include various malignancies like thymoma, prostate, sigmoid, and small cell lung cancer and teratoma, and association with hypothyroidism, thyrotoxicosis, myasthenia, and positive antibodies to acetylcholine receptor is seen in about 20 to 30% patients, and suggest the autoimmune or a paraneoplastic etiology. Increased levels of gold, mercury, and manganese also seen in few cases, suggesting a heavy metal intoxication as a possible cause. Common differential diagnosis, as I highlighted earlier, is limbic encephalitis, where we see classical cognitive features, seizures, and structural abnormalities on brain. Acquired neuromyotonia or Isaac syndrome will have absence of overt CNS and PNS findings. Another important differential would be a fatal familial insomnia, where insomnia, hallucination, confusion, and autonomic activations are commonly seen. However, here FFI is a prion disease, and the structural brain abnormalities on MRI and PET abnormalities are quite common, clear, which unlike in patients with MOR1. The most effective therapy is PLEX. Effectiveness is more significant if it is combined with immunosuppression, thymectomy, and anti-seizure medication in selective cases. However, important finding here is some cases of thymoma after surgery, because the release of the antigen, many times they can present with MOR1-like presentation. So thymectomy in cases with thymoma is also one of the, in selected cases we can consider this. Prognosis is variable. Some patients may remit spontaneously, some require PLEX and immunotherapy. Prognosis is poor in patients with thymoma. This is a Casper2 neurology, central and peripheral presentation, where MOR1 is the combination of both central and peripheral, where neuropathic pain, peripheral nerve hyperexcitability syndrome is quite common, and episodic ataxia, epilepsy, neuropsychiatric presentation, encephalitis is common as a central presentation. And this is a slide showing VGKC associated neurology, where LGI1 predominantly presents with encephalitis, hyponatremia, and classical faciobrachial dystonic seizures, as against Casper predominantly presents with painful neuropathy, encephalitis, and neuromyotonia and MOR1. That's it. Thank you.
Yeah, thank you, Dr. Datta, for that nice presentation. I have a couple of questions.
Yeah.
I just want to know how long this patient required steroids.
Yeah, actually we gave tapering steroids for about 2 months, 2 to 3 months. And then after that we tapered off, and then he became absolutely fine, because most likely what has happened in this case was the history of febrile illness prior to the onset of symptoms. So most likely it's a paraneoplastic, parainfectious etiology as a cause, and most likely it's a monophasic illness. And that's why we could taper off steroids. And we have a follow-up of this case for about 1 year after the discharge. And he is working as a teacher and no symptoms whatsoever after that.
Yeah. And another thing is that how long did it take to improve like this, whatever this myokymia that he had. Sometimes we see that they take a longer time, and then, in the initial course of the illness, they are really, really, incapacitated because of this painful myokymia that they have. And you said you gave phenytoin, and what stage of the disease that he developed peripheral neuropathy? Was it like, is it because of the drug, that phenytoin, or did he have any other comorbidities which caused this neuropathy? Because baseline, I think you said nerve conductions were normal.
Yes, yes, yes. This developed, as we when we give plasmapheresis, when he given steroids and plasmapheresis, after that he started developing severe pain at during the recovery, and then we thought we will repeated a conduction, showed a little abnormality in the snaps. However, other conduction was normal. So mild reduction. It was not a complete absence of snaps. It was a mild reduction in the amplitude compared to the first nerve conduction studies. So it was not a very frank neuropathy, but definitely reduced the snaps.
Yeah, we find that they take some longer time as compared to this facial-brachial dystonia, and sometimes really they have a very morbid and very florid course where we have lost patients with this type of Casper syndrome. It's a very nice case, and I think if there are any questions, should we go for the questions at the end of session?
They can type on housekeeping. I think all participants, if they have any questions, please type in the
Yeah,
chat box.
Dr. Datta, I have a question.
Yeah.
When did the patient develop encephalopathy? After starting phenytoin, or how long did it?
Not after starting phenytoin. Actually, he presented 2 to 3 weeks after the onset of symptoms, backache and vague body ache. After the third day of hospitalization, he was complaining of a lot of aches and pains. That was the reason why I thought we should investigate him, because mild increase in CPK and then a lot of aches and pains, and this abnormal movements were disturbing him. And the third day of hospitalization, he started developing this abnormal behavior. And hallucinatory behavior, and then for which we have to shift him to ICU.
Right, because even the acquired neuromyotonic ISACs also can have a lot of psychiatric,
Yes.
presentation. They can have a lot of depression and anxiety and all, not encephalopathy like this patient.
Yes.
Very, very interesting presentation and thing.
Other thing, did he have autonomic, sir? We had seen patients lot of
Yeah.
sweating.
Sweating.
Usually
Exactly.
Sweating is a clue many times for this
Yeah.
type of.
The thing is, what things which we have not done in our case is, one is autonomic function test, because we didn't get that much of time, and initial examination we missed the checking the autonomic, because he never complained of this thing. Once he was shifted to ICU, then he developed all the symptoms with diaphoresis and other things. So we have missed the autonomic function testing in the initial presentation.
Yeah, and Dr. Datta, we miss some of these patients. They invariably have some aches and pains. They see orthopedician, they see medicine people. That's how I think this diagnosis also is delayed because of the initial this thing. They may not even check their legs, and that's how one of our patients came after a month or so, when he had already developed a lot of symptoms. So I think this aches and pains, basically not responding to medicine, we should keep this entity in mind. And we had one patient who developed after taking androgens, androgenic steroids, developed this Casper syndrome. It's a nice case, and I think they will.
There's one question, I think, madam.
Yeah.
There's one question on the chat box asking for serology. Any serology profile was done on them?
HIV, HBsAg, anti-HCV, VDRL.
Yeah, exactly. Everything was normal. I mentioned it. Blood biochemistry, hematology, and serology was normal.
With Commissioner Chair, I think, see, we also had mandatory, like Madam is telling, we all examine everybody's cough muscles when they come with aches and pains. Invariably, everybody will be wearing pant, or this one will miss it in our busy OPD of seeing 50, 80, 100. So I think when they complain, if they come to you second time, third time with at least pain, we should examine their cough and see whether really myokymia is there, sir.
Exactly.
We have also.
Yeah, it was very prominently, toes and fingers were involuntary movements, and that was what it was remarkable. If it would have been only in the thighs and calf, maybe we could have missed in the first listing, but he came with symptoms in the toes and fingers. So that was the reason why it was picked up in the initial evaluation.
Are we seeing
Hello?
We
Ma'am,
seeing more Casper 2 in Mohammedans? Is there any, have you seen like this? Because the patients whom we saw were all Mohammedans. I don't know.
Very difficult, but it's interesting observation, madam. We'll have to see if there is any.
Datta, where was this patient? Where was this patient from? Anywhere Ballari?
No, he's
Any
from
part of
Haveri.
Haveri? Okay. I had recently one patient from Ballari who had acquired neuromyotonia. Interesting to pull the patients and write it up, I think.
Yeah.
thank you, sir. I invite Sanjay sir, who has joined us for the session. So over to you, sir. Dr. Sir,
Hello,
introduce
can you hear me, sir?
Yeah, yes, sir. Loud and clear.
Okay, it's my pleasure. It's a nice initiative by KNA, okay, which was never thought, maybe after COVID, okay. Yeah, I think the technology is coming with the picture. We can make more people to get involved if they are not coming to the conference, okay. Just introducing Dr. Suresh Dugani is a formality. More, I don't think so. It needs to really an introduction, okay. Uh, and he's the senior most neurosurgeon in the North Karnataka, and he's a very good orator, and he has presented many papers throughout country and outside country also. And I think his sir is presenting an interesting case of cervical dumbbell schwannoma, a microsurgical removal, a rare scene. Most of the time, what happens, you see this dumbbell shaped tumor either in the thoracic or in the lumbar area. Cervical area is being a difficult approach. Maybe he'll enlighten us with this case presentation. I invite Dr. Dugani sir to take over the case.
Thank you,
Dr. Dugani
Narayan.
sir.
Thank you. Thank you very much, Dr. Narayan.
Yeah.
And good evening, all my dear colleagues. As Dr. Narayan mentioned, and Madam, the Neurosciences Academy, and every year event which is happening now online, online educative sessions, and I think many people all over the state benefited with this. It's a very good initiative, and I congratulate the people who have started this program. So, not taking much of the time, I think we'll go ahead with our presentation. I thought I'll share with you interesting case of cervical dumbbell neurofibroma. I hope you are seeing the screen. Are you seeing the screen?
No,
Yeah, we
no.
are seeing the screen, sir, but slide is not.
I think
No,
like
it's a
last
video.
time you had to do, sir.
It's a video. It's a video. Huh? This is a 28 years lady presented with radiating pain in the left arm.
We are
8
not
months.
able to see the video, sir. Please, sir,
No,
like
no, no.
last time. Okay.
You're not seeing the video?
No, we are seeing your
sir.
desktop, sir.
No. Okay, then I'll share it again.
Yes, sir. Like last time, what you did, no, sir. Please do that. Yes.
Okay.
Prasad, you can guide, sir.
Yes, sir.
Now?
No,
Now
no, sir. No, sir.
No.
Last time, what you did, you had to do the same thing.
Sir, share the media player screen, sir.
Just a minute. Now?
1 minute, sir. Yeah.
Dr. Dugani sir. Sir, you can open your video and share screen.
Yes, sir. It is up.
Yeah, right now
Yeah,
it's seen now.
Okay, yeah.
Neurofibroma cervical C6, where this was operated both anteriorly. It needed anterior approach. Both the surgeries were done at the same time. This is about a young lady of 28 years old, presented with radiating pain in the left arm, weakness of the left grip, and all were progressive. Weakness of lower limb of 3 months. Exam she had left grip weakness, left supinatal jerk absent, left C6, C7, dermatomal hypoesthesia, spasticity in both the lower limbs, with the brisk deep tendon reflexes with the spastic gait, suggestive of cervical radiculomyelopathy. With this, she was investigated with a MRI scan, a cervical spine and a whole spine screening, showed a large dumbbell schwannoma as shown. I hope these pictures are clear. This is a tumor there, situated part of it inside the spinal canal, and majority of it is going outside the spinal canal through the widening of the intervertebral foramen and getting into the paraspinal region. These are the various sections. This is the axial section, and this is the central section inside the spinal cord with a significant pressure on the spinal cord. And this is the intervertebral foramen coming out. And it was going down into the anterior part of the neck and going on to the pleura and touching the superior pleura of the lung and going up to the anterior part. So this is the MRI picture showing this. This is where it is situated, the upper part of the chest on the pleura. You can see the lesion here, and quite a big lesion starting from the neck, descending down into the onto the anterior part of the chest. She was taken up for surgery, and first stage we did a prone position. In the posterior approach, we did a C6 hemilaminectomy. Lesion was situated on the left side, and we took off the neurofibroma which was in the spinal canal and extradural space. Second stage, same anesthesia. We turned the patient. These are the posterior approaches. You can see the hemilaminectomy has been done on the left side. This is the dura mater, dural tube. What I would like just to mention the neurology colleagues that what you discuss about the nerves and the spinal cord, we can see them live with our what we present, and you can have that anatomical and physiological correlations. So this is the spinal cord, the dura mater, and this is the ligamentum which we are taking it out, and we drill the facet joint and the intervertebral foramen completely and expose the nerve root. Now we are drilling the laminae upper part and laminae lower part, and we are exposing the tumor which is coming out of the intervertebral foramen. So drilling is done and the bone is removed, and you can see that the tumor is coming into view. This is the dura mater, that's the spinal cord inside, and this is the tumor, the extra spinal part of the tumor or extradural part of the tumor. And now the bone is drilled. See, the issue here is you must expose the lower part of the tumor and the upper part of the tumor completely, so that you, during the dissection and excision, you will not leave behind the tumor and not harm the surrounding neurovascular structures. This is the extradural part of the tumor. You can see the tumor here, and this is the dura, and tumor is going inside the dura, and this is C5 nerve root. This is dura mater inside. Now, what you do the first stage, the tumor which is extradural outside the dura mater and inside the spinal canal, we excise first microsurgically. This is being done under a microscope with a high illumination and high magnification. And this is very important. Such tumors always, majority of the neurosurgical procedures are to be done with a microscope or an endoscope. And the outcome in these cases is excellent. Now you see the tumor here completely exposed in the extradural part, and it has compressed on the C5 nerve root. That's why when you examine these patients, even though the tumor is from here, you will have many root involvement and many of the upper or lower root involvement, giving a false impression. Now the extradural part is dissected now, and the tumor is separated, and the part of the tumor going out of the intervertebral foramen. This is the intervertebral foramen from where the tumor is going into the neck, that is the paraspinal region. Now everything is, as I mentioned, illumination and high magnification. This we are operating at 10 times magnification. Now that is the part of the tumor which is soft, and they keep bleeding and you keep coagulating and cutting. Now you see the extradural part, intracanalular part is taken out completely. This is the nerve root, that's the C5 nerve root which is elevated by the tumor. Now we are taking off the tumor completely from the extradural part and the part of the tumor which is going in paraspinally. So this is the intraspinal part of the tumor, and root is released completely. At every stage, we keep achieving the hemostasis and take out the tumor. Now we have removed the tumor completely inside the spinal canal. As you go deeper and deeper, there will be some amount of extradural bleeding from the anterior and the lateral aspect of the spinal cord or spinal the dura mater. We need to achieve the hemostasis, stop bleeding at every stage with the bipolar, and remove the tumor. This is the complete excision of the tumor inside the spinal canal, outside the dura. Now you see the C5 nerve root, which was not seen before, which was elevated and shifted superiorly. Now the tumor, the root is coming into picture now. So this is the dura mater, and this is the C5 nerve root, and the tumor with the C6 nerve root has been taken out completely. Now the part of the tumor in MRI, we saw tumor is inside the dura mater. So now we open the dura mater, and part of the tumor which is inside, we will take it out. Otherwise, tumor will remain there. The myelopathy of the patient will not improve. Now this is the nerve root. Are you seeing the nerve root here? And that's a dura mater. And the other 6 is nerve roots are seen. Now these are the nerve roots under high illumination and magnification. Arachnoid, usually these tumors are inside the arachnoid, and we open the arachnoid and separate the tumor and bring it out. We cut the dura on the surface of the tumor and make a space for the tumor to be removed. Now you see the whole tumor inside the dura mater, anterior to the spinal cord, anteriorly and lateral to the spinal cord is being delivered, dissected, and taken out completely. Now you see the tumor from the anterior aspect of the spinal cord attached to the C6 dura, C6 nerve root, which is non-functional. That is, we call it as proximal mother root. That is the root from where the tumor is arising. Invariably, these nerve roots from where the tumor arises, they will be non-functional. They're not functional. You can coagulate and cut the nerve roots and release the tumor. Many a times it happens that surrounding nerve roots, they go on the surface of the tumor. We need to recognize those nerve roots which are coursing on the surface of the tumor, or the tumor is originating from the nerve roots. The nerve roots which the tumor originates only need to be cut because already they are non-functional. Safely the tumor can be removed. Now you can see part of the tumor which was inside the dura mater, and onto the spinal cord anteriorly and laterally taken out completely. Now you can see the CSF coming out, and that is the spinal cord inside the cervical spinal cord. Now we close the dura mater, achieve as much of the dura mater to avoid CSF leak. That is the C5 nerve root well preserved, and dura mater is closed so that the CSF doesn't leak. We take a small muscle patch here, the dural loss is there because of the tumor, and put it as a graft and close the dural opening, put a tissue seal all around it so that the CSF leak doesn't occur. This is the first stage of surgery, the intradural, intraspinal. We put a metal foil inside the tumor, which is very important and very nice. Now, because when we go anteriorly, these are the two metal foils. We push inside the tumor, which is in the extra spinal, paraspinal cervical region. Now, once we do that, we close at this wound posteriorly, and next turn the patient supine, and at that juncture we take an X-ray. This is the X-ray which you take before we start the second procedure. Now these are two metal foils which we pushed inside the tumor. You can see those metal foils here, which suggests the tumor is situated there at that juncture, and we need to open that much part of the anterior cervical spine. Now we turn the patient supine, and this is our area of access. We make a flap, cervical, anterior cervical, and the skin is elevated. Anterior part of the sternomastoid and posterior part of sternomastoid are recognized, and this is where the tumor is situated. We expose the area between the posterior part of sternomastoid and the paraspinal muscles. Now you can see we have reached the tumor very easily and simply. One important thing you must remember here is this is the location where all the nerve roots from the brachial plexus, they come along with the side of the tumor. They may be on the side of the tumor, or they may be inside the part or the anterior part. At this juncture, we keep doing intraoperative electrophysiological monitoring of the nerve roots. At this juncture, we have an intraoperative neuromonitor, that's INM, and we keep on checking the electrical activities that we are not disturbing any of the nerve root. Now, all the nerve roots surrounding the tumor are separate. This is very critical because if we don't do this, you may take out the tumor and patient may have brachial plexus injury and wake up with the weakness. Now, the capsule of the tumor is removed, cut, and now what happens is we do an intratumoral decompression. That is, the ultrasonic cavitron aspirate, sucks the tumor and reduces the bulk of the tumor. Very important because the place is very narrow and surrounding we have brachial plexus root. Only the capsule of the tumor needs to be excised. Now you see the capsule is separated. We have intervertebral foramen there. There we left the posterior approach. Now we have reached from anteriorly now. Now I want you to see the metallic foils, silver foils, which we had placed when we approached posteriorly. We have reached that. That suggests that we have reached the intraorbital foramen completely from the spinal canal. That is the intraorbital foramen, and inside the tumor from the surrounding the foramen excised completely, and
So you're not audible.
tumor surrounding. Yeah. Now there's a little technical problem. Now the tumor surrounding the foramen is cut and taken out completely without harming or without injuring the surrounding brachial plexus nerve roots and the fibers. That is the tumor which was going onto the pleura. Again, we need to be very important, very clear here, not to damage the pleura. If you damage the pleura during dissection, patient may develop pneumothorax and we may have to put an intercostal drain. This is the pleura which we are separating now, the inferior part of the tumor from the surface of the pleura, superior pleura. Gently under illumination, high illumination and high magnification, the tumor is separated, and the surrounding nerve roots are separated and disseminated. And that's pushing, we are pushing the pleura downwards and only pulling the tumor outside. This is the complete dissection of the tumor inside the anterior part of cervical spine. Now, when we dissected, this is very important. When we dissected, you saw the proximal mother root from where the tumor was originating, and this is the distal mother root, which is leaving the tumor, and in between the tumor is originating. This is the distal mother root, needs to be recognized and cut completely because, as I mentioned to you earlier, these nerve roots are usually non-functional, and that is the complete excision of the tumor, separation from the distal mother root and the proximal mother root, and you can see the surrounding nerve roots very well preserved, and this is only possible if you use a high end of microscope with high illumination magnification with neuroelectrophysiological monitoring continuously. You can save the brachial plexus and all the branches. The whole tumor is taken out now completely. That is the part of the tumor separated. And again, we debulk or reduce size with ultrasonic aspirate. This is a very important instrument which reduces the size of the tumor without injuring the surrounding structures. Now the tumor is separated from the intervertebral foramen. Foramen connecting the spinal cord, that is inside the spinal cord here, and this is the peripheral part, and the surgical and gel foam what we put during the posterior approach, you can see through the intervertebral foramen. Now that's the end stage of surgery. Complete excision has been done. That's the internal carotid artery, which has been pushed, which will retracted towards medially, and the paraspinal muscles, the posterior part of sternocleidomastoid, and these are all the neck muscles at the anterior triangle of the neck. That is the internal carotid artery brought back into its own position. The deep cervical fascia is closed, and the scalp is the skin is closed. This is her post-operative status on day 2. She is moving all the 4 limbs. There is no brachial plexus injury. This is on day 5, the day of discharge. She is perfectly normal. Thank you very much. This is the end of the surgery. Thank you.
Hello. Hello.
Dr. Dugani, sir. Yes, we can hear you. Sir.
Yeah, it was definitely a nice presentation. Okay.
Thank you.
A best illustrative of both microsurgical techniques. I got only one small technical nuances.
Yes.
There's a new idea of putting into the intervertebral foramen whatever the metal object. Okay. Could you have used the high, intensity ultrasound for the extradural lesion in the neck? Ultrasound instead of taking the X-ray. I think it would have been much better because the lesion was a bit bigger. It would have been picked up by the ultrasound.
No.
The neck.
No. Thank you, Narayan. Excellent. Yeah. It's a very important question and very valid question. Definitely. We can use intraoperative ultrasound to look at the tumor. Definitely. So here it is so simple that, just put a metal foil and take an X-ray, miss the lesion. We can do that, what you just mentioned.
Yeah, and definitely. More importantly, instead of X-ray, ultrasound would have been more of a dynamic investigation. You can identify the exactly entry depth, and you can even, in fact, identify the metal object. You can identify the bony structures. You can identify the vascular structures in the posterior triangle. In fact, you can identify the nerves, which is widely used by the anesthesiologist. In fact, while giving the blocks and other things, they identify the nerves while giving the brachial block. Same thing. You could have. This is my suggestion. That's it. Okay.
Yeah.
What do you feel, sir? What do you feel with your experience?
No, I 100% agree with you. Not two opinions about it. Ultrasound is definitely an invaluable tool in this. No doubt about it. But only thing what happens is the procuring the intraoperative ultrasound and with the probe which is required for that. It again the newer expensive tool in the operation room to use that. And very few people can afford to have an intraoperative ultrasound. So now what is happening is this type of one, and soon we are going to install the intraoperative CT. Again, that's another part. But definitely it is useful, no doubt about it.
What about thank you, sir. Thank you. It was nice illustration.
Thank you.
Thank you, sir, Dr.
Any comments from other participants, surgical colleagues?
Let's see if there are any questions.
Sir, we have 2 raised hands. I'll just allow them to speak so that Dr. Anirudh, you can speak now. Your hand was raised.
Anirudh, you are muted.
Sir.
Now you wanted to ask a question.
No, I think
there are two Anirudhs.
Must be one more Anirudh.
There's one
Anirudh TJ.
Bangalore.
Anirudh TJ,
I think, from Bangalore. Has he posted a question?
No, he hasn't. We just have
He
another
has not
doctor.
typed the question, so we'll
But
ask
anyway,
them
you
to
can,
type the question, sir. I think we can move
Yeah.
ahead.
Yeah.
We
Saroja
have
madam.
another doctor
Yeah.
who has raised a
Yeah.
hand.
Yes,
So,
yes. Vasan
Was-
is there. Does
Yeah.
he? But he's muted.
Yeah, hello. Can I?
yeah, I think
Am I
he's there, sir.
audible?
Yes, Vasan.
Yes, sir. Vasan, sir. Please go ahead,
Yeah,
sir.
yeah. Good evening, Dr. Dugani. Very well
you.
illustrated and very nicely spoken as expected.
Thank you.
Yeah, I mean, I was just trying to add up for the Dr. Narayan Panji that ultrasound, this is a large tumor. So easily it was found, I mean, from the anterior aspect also. And only thing is, like Dr. Dugani said, to know the posterior most aspect of the tumor, so that we
Yes.
don't leave any other tumor. That I think that X-ray markers was helpful. I agree with that. But if it is a small one, and if you miss it out in the during dissection, that's what I'm little worried. That small markers at the end.
No, see about missing the markers.
Yep.
Now, what happens is if you can the markers are in the tumor itself. We put it inside the tumor itself, not outside.
Inside the tumor. Okay, right.
Inside the substance of the tumor.
Okay.
So as you keep dissecting from below, and they are about 2 centimeters in size. 2 centimeters.
Okay.
1.5 to 2 centimeters. So as you keep dissecting, they're inside the tumor. You'll not miss them, and always you keep looking for them. Always, yes.
Okay. All right.
Nice.
Yeah.
Yeah.
So that was a nice case, Dr. Dugani,
Thank
sir.
you.
Anyway, it is Greek and Latin for us, the surgical approach. Anyways, yeah, I would like to welcome Dr. Bhushan, who's going to speak on an unusual case of recurrent arterial stroke. For those of you who do not know Bhushan, he is a MD from Belgaum, and then he did from Bombay, KEM, now currently with the Hubli team. So I would like to welcome Bhushan to present his case scenario. Over to Bhushan.
Thank you, madam. Thank you for the. Are you able to see my screen?
Yes.
Slide show ಕೆಳಗಿದೆ ನೋಡಿ ಭೂಷಣ್ ಕೆಳಗಿದೆ.
Next. Next to that.
Yeah, it's fine.
Yeah. So I'm presenting an unusual case of recurrent arterial stroke. So the story dates back to 2011, when a 42-year-old male, known case of hypertension, presented with history of recurrent episodes of left-sided weakness since last 3 months. This was his MRI brain done that time, which showed acute infarct in the right parietal area. His MRI angio showed right IC occlusion. His Doppler showed a non-calcified plaque in the right carotid bulb, extending it to the proximal ICA, causing around 80 to 90% stenosis. All his routine lab parameters were normal, like the CBC, sugars, RFT, LFT, lipid profile, and the viral markers were normal. His ECG and echo was also normal. He has a significant past history in the form that he had undergone coronary angiogram in 2010, which was normal, which was done through the radial artery route. So during that episode, he developed a radial artery thrombosis and had to undergo thrombectomy. Since that time, he was on amlodipine 2.5 mg and antiplatelets. In spite of that, he was having recurrent stroke. He doesn't have any significant personal history of any habits. He has a significant family history in the form that his younger brother died at age 39 with an MI and sudden cardiac arrest. In view of recurrent symptoms, right ICA problems, even on antiplatelets, the patient undergoes a DSA, which shows a right ICA proximal stenosis and undergoes plasty with stenting. Post the stenting, when he undergoes a routine Doppler evaluation that shows the stent thrombosis. So this patient is again re-evaluated as young stroke, minimal hypertension, no other risk factors, strong family history of early MI death in the family, that is the brother, with a recurrent thrombosis, radial artery, ICA, and the stent thrombosis. So he was evaluated by the lab parameters for the thrombotic profile. The serum homocysteine level was normal, ANA profile was normal, antiphospholipid antibody profile, which included lupus anticoagulant, anti-cardiolipin antibody, and anti-beta glycoprotein antibody. IgG and IgM were normal. His activated protein C registered factor V laden functional assay was normal. Protein C and antithrombin levels were normal, but it showed a protein S deficiency. So we thought this patient is a case of thrombophilia disorder, recurrent thrombosis with even on antiplatelets. So he was started on anticoagulation. This is his current prescription. He doesn't have any episodes since last 2011 to 2023. He's on Telma 20, Ecosprin AV 75, and WARP 6 mg, 7 mg alternate day with INR of 2.12. The story takes a twist and turns when his younger brother, 47 years, develops acute left hemiparesis in 2019. His MRI showed acute large right MCA infarct, and as expected, all his evaluation led to the protein S deficiency. So the family and this patient again, his brother is on Ecosprin AV 75, WOF 3 mg OD with a current INR of 1.83 and oxetol 300 mg 1 BD as he developed an episode of seizure. He is also has left side, he has a deficit, but he is asymptomatic. He didn't have any new episodes since 2019. In view of recurrent strokes, MI, and death, the family, as well as we think something is going on in the family, so evaluate the complete family. So this is the family. This is the elder brother who died with an MI at the age of 39. And because of this is the proband patient who has protein S deficiency and recurrent arterial stroke. This is the younger brother who developed a stroke, second episode. Then we start testing protein S levels in the family. We found that the protein S levels were normal in the elder two brothers who are 62 and 59. We find out that the children of these two people who are asymptomatic also show the protein S deficiency. And protein S levels have been tested in these patients at multiple times, multiple assays like a total protein S antigen as well as the functional assays have been tested, which show significantly lower levels. So as we all know, protein S is a vitamin K dependent protease that keeps the blood in non-thrombotic state. In circulation, approximately 40% of the protein S is free and about 60% is in binding to the high affinity complex with complement regulatory factor C4b binding protein. Protein S operates as a cofactor for activated protein C and inactivates the coagulation factor 5A and 8A. Protein S is also a cofactor for the tissue factor pathway inhibitor protease, resulting in the inactivation of the factor 10A and tissue factor 7A. So protein S basically is a coagulation suppressant. So deficiency of protein S leads to coagulation, that is thrombosis. Protein S deficiency can be hereditary or it can be acquired. The causes of acquired protein S deficiency are hepatic diseases, syndrome, vitamin K deficiency or anticoagulation. Sometimes pregnancy, OCPs, and inflammatory diseases can also lead to low protein S levels. The exact prevalence of protein S deficiency is not known, but it is supposed to be 5 to 10 times more common in Japanese population than in whites. It is supposed to be 0.48 to 0.63% in few of the Japanese population where they are studied, and around 12.7% in patients with thrombosis. So hereditary form presents with a autosomal dominant mode, but it has a variable penetrance. Rare homozygous forms present in the neonatal form with a purpura fulminans at the 4 weeks at the onset in infancy. The commonest form are the heterozygous, which present with venous thromboembolism in younger than 50 age. 50% of the patients who are heterozygous for the protein S deficiency develop venous thromboembolism. The remaining 50% are asymptomatic and never develop venous thromboembolism. So coming to the laboratory studies of protein S deficiency is usually evaluated as total protein S as well as the free protein S antigen levels. as well as the functional proteinase levels. Once you diagnose it as a proteinase deficiency, then if you want to confirm it as a hereditary cause, then we can do a proteinase, that is PROS1 mutational analysis, which is situated on the chromosome 3q. There have been more than 200 genetic mutations associated with proteinase deficiency. PROS1 mutations are reported with type 1 and type 3 deficiency. There seems to be no correlation between genotype and phenotype of PROS1. These are the three types of proteinase deficiency, type 2 being very rare, type 1 and type 3 being very common. In all the three, proteinase activity is low. Free protein levels are low in both first and three types. So total proteinase is low in type 3 and it is normal in type 3 and it is low in type 1. In our patients, all the three levels were low, so they were having probably a type 1 proteinase deficiency. That's what I already told. But usually proteinase deficiency is associated venous thrombotic episode, and association with arterial stroke is little unusual. So to associate that with arterial stroke, either one, we have to rule out the known causes of acquired hemophilia, which we have done in all these patients. And otherwise, second point is one, to demonstrate that there is a hereditary cause of proteinase deficiency. Either you have to show a PROS1 mutation analysis, or you have to show a family history with a significant diagnostic levels of proteinase. Even though we did not do proteinase mutational analysis in these patients, the significant family members being affected shows that it's a rare presentation of arterial stroke with familial proteinase deficiency. Then coming to the treatment of proteinase deficiency with arterial stroke, the AHA 2029 guidelines say that in patients with ischemic stroke or a TIA of unknown source, despite a thorough diagnostic evaluation, that is the first episode, if you are getting proteinase deficiency, then only antiplatelet therapy is the reasonable for these patients. So usually we face with three type of patients with proteinase deficiency. That is the asymptomatic family members that we are facing now. Probably nothing needs to be done for them except in the high risk situation like prolonged bed rest, major surgeries, or in the pregnancy, they may be given a short course of oral anticoagulation. Second is the first episode of stroke with a proteinase deficiency. If you go by the guidelines, then only antiplatelets are indicated. If patient has recurrent episodes or a positive family history, then probably anticoagulation for the lifelong. Thank you. Thank you, Vanessa.
Yeah, thank you, Dr. Bhushan. And I think it's a very nice presentation, because we see a lot of venous thrombosis. At least
Yeah.
1/3 of the patients most often have this acquired or hereditary thrombophilia. Only problem is that probably you'll have to look at the quantity, like, they give the titers, they give the quantity. So if it is mild proteinase deficiency, you may not have to worry so much. But if the levels are very low, probably you should still consider, giving them medication, because these patients, if you look at their history, they have developed at little later age, like, 40s. In their 40s, both of them have developed in their 40s, and the children are young. And now probably you'll have to look at quantitative analysis of proteinase. If they are low, I think I would always keep my fingers crossed that we do not know when they are going to develop. And sometimes probably you'll also have to look at other features which can cause acquired, worsening of this proteinase. Like, all of them, I'm not sure if they were males, no?
Yeah, they are males.
They are males,
Yeah.
so that is
Female
one.
is there is a problem because
Otherwise, if
pregnancy.
they are females, I would always, if they are going for a pregnancy, I would strongly advocate, heparin in them during pregnancy because of this. So I think this is not just a diagnostic dilemma. I think it's also a therapeutic dilemma for the kids who have this. Probably you should look at the quantitative analysis of this. That's one thing. And we have that genotypic phenotypic variation is there, because we have seen patients with familial venous thromboembolism, and then they develop pulmonary thromboembolism. And one patient who has both concurrent, MI and then this thing. But arterial, we do not see that commonly. It's a very nice eye opener for us. it's a very good case, I would say. And let us see if there are any questions or.
Yeah, nice presentation, Bhushan. I mean, sometimes you give up because you test always protein C, protein S, antithrombin 3. Most of the times it comes negative. Then you feel at some stage that why do you need to do all these things for stroke? But your case brings out the point that you never stop investigating, especially when there is a recurrent event. Yeah, I agree with Dr. Saroja. We need to I think have a close watch on the kids who are positive. I think family have to be, I think, have to be sensitized towards that. There is a high risk that maybe at 20s, 30s, will have to be carefully monitored, and if required at some situation, I think they need to be, medicated for prevention of stroke. Thing. Another thing is whether the patient underwent angioplasty. Was there any atherosclerotic element also, or was there only thrombotic?
Stenosis with thrombosis.
Okay.
Yeah. So Bhushan, another question for you. Do you have to combine antiplatelet and anticoagulation in them when you already know that this is like he was asking a question whether there was atherosclerosis? So would you go ahead and give both the drugs or give only anticoagulation?
The patient was already on antiplatelets, madam, double antiplatelets. So actually,
No,
we
I'm
had to start
asking, should we give both?
Ideally, if it
Because
is only
the chances of
anticoagulation.
them bleeding, see, you will have to give them lifelong now, anticoagulation. Now, would you combine with the aspirin, and what was the role of statin in them, these patients?
Because it's all started with cardiac, they were already on antiplatelets.
Yeah, okay.
So
So that question, no, we have to ask whether we should
Yeah,
continue or that's
But
not.
he also has hypertension, no, ma'am. He has mild
Yeah,
hypertension.
that is there. They can develop a bleed also, hypertension.
Yeah.
Yes, ma'am. So actually, the other question is the question is NOACs can be given in this patient. So there are actually only apply it is absolute means right now not indicated. So this warp monitoring NOACs also can be given.
They can be given. Anyhow, they are stabilized for last 10 years from
Yeah, that's true.
2011. So we continued with anticoagulation.
Yeah,
But if
so
a new patient,
yeah.
NOACs can be considered.
Personally, madam, actually, we also give 75 mg of aspirin and this anticoagulation on these patients. They are doing fairly well. In an arterial stroke, ma'am, in a venous stroke, we are definitely only giving anticoagulation. Since it's an arterial, we see mechanism of stroke, even though theoretically, but in a given patient, it is difficult. Because as a clinician, we know. So it is most of the time we give low dose antiplatelet with INR keeping around 2. I think many of our patients are doing good, ma'am.
Because all the sites of thrombosis was where there was an intervention. Whether it was a radial artery, whether it's a stent,
I think
all it was all endothelial damage. So probably there is a element of atherosclerosis there. So probably endothelial damage. So probably statin and aspirin probably along with anticoagulation probably makes sense.
Okay, there are no further questions. I'd like to ask, thank you, Dr. Bhushan. Dr. Panji to introduce Anirudh and we can have discussion.
We have come to the last session of the today's webinar. It's my pleasure to introduce Dr. Anirudh. I think he's a contemporary and he's a senior neurosurgeon practicing in Neuro World Center at Hubli, and I think he's a visiting consultant at Suchai Hospital, Hubli, and he's alumni of prestigious NIMHANS. Just like he's following footsteps of Dr. Suresh Dugani, he established himself as a senior neurosurgeon in Hubli. I invite Dr. Anirudh to present his series of osteomas of the skull.
Yes.
Thank you,
Thank
Dr.
you, sir.
Anirudh.
Thank you, Panji, sir, for
Yeah.
introduction.
Yeah.
And thank you so much for the KNA organizers for initiating this and giving me this opportunity to share my experience with this topic, frontal osteomas and their rare presentation. Are you all able to see the slides?
Yeah, Andrew, go ahead.
Yeah. Next. It's not shifting. Next slide.
So use the right cursor key. Right cursor.
Yeah. Straight away go with the case presentation. I had one patient, 45-year-old gentleman. He was a bank manager. He came to the emergency department in our hospital with a history of 3 days history of fever and headache, and 1 day history of altered sensorium. Prior to that, he had visited Goa in the summer in April last week. Then he had fever, headache, and was in deep altered sensorium. No, he was as the comorbidities. No, he was not a hypertensive or diabetic. On examination in the emergency department, his GCS was he was opening eyes to painful stimulation, localizing with his left hand, and incomprehensible sounds. GCS was 9/15. Pupils were equal and reacting. He had a mild right hemiparesis, and because of fever he was febrile, and severe neck stiffness was present. The important finding was his left forehead was boggy swelling was there, and with underlying bony defect. This is the scan. The immediate CT scan was done, which showed there is a large craniectomy defect was there, and you can see a hyperdense lesion in the left basifrontal region, which was almost of a bony density, with underlying ventricles which were big. There was a asymmetric ventriculomegaly. Left frontal horn was bigger than the right. There was also a rounding of the third ventricle. Bilateral temporal horns were dilated. Fourth ventricle was normal. And there was a lot of edema, especially in the left frontal region, and which was extending up to the centrum semi-ovale. And the CT bone windows showed, you can see a hyperdense bony density lesion arising from the nasoethmoidal region going into the frontal sinus, eroding the skull base. And there was a large craniectomy defect. MRI was also done in the earlier stages, and which revealed, along with what we saw it in the CT, this added more information with the contrast MRI, which showed again a heterointense lesion in the left basifrontal region, which was almost like taking origination from the diploic spaces of the frontal sinus. And there was important finding was there is a lot of enhancement of the left frontal region adjacent to this lesion, and also there was an ependymal enhancement of the ventricle. Again, there was asymmetric ventriculomegaly, and there was perilesional edema, and significant hydrocephalus was there. In view of his deep altered sensorium and hydrocephalus, this is all in the emergency department. Because his GCS was poor and there was a significant ventriculomegaly and that craniectomy defect, there was a boggy swelling. We had to, with this clinical profile and the imaging, we thought of a neuroinfection, especially the ependymal enhancement. We thought of a ventriculitis, and he was immediately put external ventricular drainage on the right side, because left side there was a large craniectomy defect. And the CSF was turbid, cell count was very high, more than 1,000 cells, glucose was low, protein was 241. At this point, the past history I want to highlight, it was a very significant past history. He had undergone surgery in Pune in 2016. He had come to me in April 2023. So he had undergone surgery for the left frontal lesion, and he had a craniectomy defect. Actually, he had gone to a hospital to see his mother-in-law who had undergone cardiac stenting, where in the hospital only he had 3 to 4 episodes of seizures. So in the hospital, he was immediately taken up for CT scan and MRI, and he was told to have a left frontal brain tumor. And he underwent the next, after 48 hours, he underwent surgery also. And his HPR had shown diffuse astrocytoma grade 2. This is, I could retrieve the histopathology report from 2016. It had written diffuse astrocytoma grade 2. And the surgical details, further surgical details were not available with the relatives. And the exact reason for not keeping back the bone flap was also not clear. Relatives were, because it was, they had told that the tumor is still, there is a lot of residue is there and they could not remove. And probably there was a brain bulge, I could correlate. Relatives were counseled about the radiation therapy because it being a glioma. In view of a residual lesion, patient underwent radiation also in 2016 itself. This is the scan which was in 2016 when he had gone to the hospital where he had repeated seizures. You can see on the MRI there is a heterointense lesion in the left frontal region. Looks like an intraaxial lesion, but the origin is abutting the frontal sinus with areas of hypointensity and hyperintensity, a lot of edema, and it's causing significant mass effect on the bilateral frontal horns of the lateral ventricle. Also, CT was also done during that time. It had shown again mainly osteosclerotic and a few osteolytic areas, hyperdense bony density lesion. After his surgery and he took radiation, he made a gradual recovery. This is what I could get from the relatives. In 2017, after a few months, probably 7 or 8 months after the surgery and radiation therapy, he got transferred to Hubli branch as he was a bank employee. I mean, after 4 months, he started going to the bank, although he was a little dull and his speech was a little disturbed, but he had joined. He used to have, after coming to Hubli, he used to have infrequent seizures and was under a neurologist follow-up. And also after repeatedly reviewing the history with the relatives, they told there were episodes of 3 to 4 episodes of watery nasal discharge, which were transient and no evidence of any meningitis. This time he came to us with, as I told, fever, headache of just 3 days and altered sensorium of 1 day after his Goa visit. So the EVD, as I told, in the emergency department, we had to put a right frontal horn external ventricular drainage, which showed a significant cells. And the empirically, he was started on vancomycin and ceftriaxone at anti-meningitic dosage. Patient was closely monitored in ICU with repeated CSF sampling. This picture shows the cell counts from within a week. From 500 cells, 1000 cells, 1054 cells, despite being on vancomycin, ceftriaxone, did not show a decreasing trend. Because he was put on EVD and there was the ICP was taken care, he made a mild marginal improvement in his sensorium. He was drowsy, occasionally he used to obey. Because of frank ventriculitis, cell counts not showing decreasing trend after 1 week also. All these two cell cultures, CSF cultures were negative. So because of this, we thought of intraventricular antibiotics along with the systemic antibiotics. Initially, he was given intraventricular gentamicin. Then after 3 days, we immediately switched over to colistin. There are a few antibiotics which are recommended for intraventricular usage along with gentamicin, colistin, polymyxin, amikacin. So systemic antibiotics were continued for 3 weeks. His EVD was regularly changed every 6th day and CSF sampling was also done. After 2 weeks of intensive management, a ventricle CSF started showing declining trend, especially when he was given intraventricular colistin. Patient started noticing improvement in his sensorium gradually. He stayed in ICU for almost 26 days and EVD was later was removed. All these days, because of ventriculitis, which has got a high morbidity and mortality, the guarded prognosis was told to the relatives. All CSF cultures were showed no growth. PCR was not done. After EVD and putting EVD and antibiotics, even the craniectomy bulge, which I had told earlier, also got subsided. So he almost stayed for 5 weeks in the hospital and he was discharged. And just to, so that he will be planned for definitive treatment at a later date, we thought we will give him time because he is coming out of this infective period with a close follow-up. He was called after 3 weeks. He was, that time he was conscious. Mild speech difficulty was there and mild hemiparesis. Imaging repeated showed the frontal lesion again with a reduced ventricular enhancement and no hydrocephalus was there. This is the scan. And again, there is a large bone density lesion with a craniectomy defect. So basically, reviewing the imaging and clinical profile, it was a frontal osteoma causing skull base erosion, communicating externally because of erosion of the nasoethmoidal area. He had 3 to 4 episodes of CSF rhinorrhea, and there were, because the frontal osteoma was causing dural tear at the basifrontal region and was causing mass effect on the frontal lobe. He had got a infection from meningitis to the ventriculitis, and there was a large craniectomy defect. Hence, keeping in view, once the infection was under control and we had to address his primary pathology, which is the osteoma, which is eroding the skull base. So he was planned for major surgery, re-exploration of the frontal area where the surgery was done, drilling of the osteoma, and looking at where all the defects are there, closing it up with the ACF-based carpeting, repair with the facial autograft, fibrin glue, exteriorization. And it was because there was a craniectomy defect for almost 2016 to 23. So almost 7-8 years. So we planned for cranioplasty also at the same time. These are some intraoperative picture. You can see the frontal osteoma eroding the skull basal dura and also causing mass effect on the frontal lobe. And also frontal sinus osteoma, you can see here with the erosion of the basal dura communicating with the nasoethmoidal area. So what he was done was, he was taken up for a bicoronal flap, drilling of the frontal osteoma, and looking at the basal dural repair with a facial autograft and exteriorization of the frontal sinus from the frontal lobe, and also repairing the dural defect on the frontal lobe. You can see there is almost a basal dura and it's directly communicating with the ventricle. So he had a direct communication. That's why he had developed a frank ventriculitis. So after exteriorization of the frontal sinus, he was procured a titanium mesh according to the defects. We had created a titanium mesh and it was implanted. Cranioplasty was done with customized titanium implant. Patient made a very good recovery. His speech and hemiparesis also improved to a greater extent. That could be probably because 7-8 years, the craniectomy defect, the brain was sunken. It looked like a sinking skin flap syndrome or a trephination syndrome, we tell. And he was discharged in a stable condition with close follow-up. Because he had a ventriculitis, we always thought he may come back with hydrocephalus. After 4 weeks, he started developing repeated vomiting, imbalance while walking, and dullness. Repeat imaging revealed, again, hydrocephalus, asymmetric, mainly involving this is the scan. After the cranioplasty, you can see there's again the ventricles are bloomed again. You can see the subdural hygroma, even the CSF above the titanium mesh, and there was a lot of edema, bilateral frontoparietal significant edema, basically a hydrocephalus, and there was no enhancement of the ventricle, and there was no fever. In view of post-treated ventriculitis, hydrocephalus with a raised ICP, he underwent left ventriculoperitoneal shunt, medium pressure. After this, he was closely followed up and he made a very good recovery. At this point of time, I thought of reviewing his histopathological slides, which was done in Pune. We could get it from there, and we reviewed the slides, and they were suggestive of osteoma. There was no glioma at all. So this could be, we thought probably the frontal osteoma had created a sort of mucocele and had significant mass effect on the brain, frontal lobe. So that might have created a gliotic areas and probably was misinterpreted because of some glial tissues. So it was interpreted as a glioma. So it was basically osteoma with a significant mass effect on the frontal lobe, causing a dural tear, causing CSF rhinorrhea, causing meningitis, leading on to the ventriculitis. So this is just in 2 slides. There is one more similar case I had got, but this guy had presented with a pure motor aphasia and only on and off headache he had. He was also 45-year-old. He just came with a pure motor aphasia. The MRI and CT scan, you can see there's a large hyperdense lesion in the frontal, basifrontal region from the frontal sinus, and you see a large pneumocephalus, tension pneumocephalus. That's because the frontal osteoma is eroding the dura, basal dura, and it's a one-way communication. The air is accumulating, and when it is significant, it's causing pressure on the speech area and the frontal lobe. So he also underwent the drilling of the frontal osteoma and exteriorization of the frontal sinus and the dural repair. So basically, these two cases are so enlightening that there's so many things to learn from these two cases, I felt, starting from uh, correlating the imaging findings with the clinical profile, having a proper clinical acumen, and again, reviewing the slides. Then when the ventriculitis is there, there's the constant vigilance, constant perseverance to tackle that ventriculitis, again with the intraventricular antibiotics, which showed gradual improvement. Then post-ventriculitis, he developed again hydrocephalus, which was again addressed with a V patient. And finally, he has made a good recovery. So to a few slides about the frontal osteomas, which we routinely find in our incidental finding in our CT scan or MRI. They can be found at any age, most frequently found in people above age 40 years. Diagnosis of osteoma is by chance, mostly present with headache. Rarely they can present with ophthalmological and neurological complications because of a locally invasive growth. Most dreaded complications are it can develop a mucocele. From there, it can rupture, cause a dural tear, bacterial meningitis, subdural empyema, and ventriculitis. So frontal osteomas are slow-growing benign encapsulated tumors. Majority are asymptomatic. Incidence is 1% of all X-rays, 3% of all CT scans. So lessons to learn from this case: frontal osteomas, although rare, can present in most complex way with a lot of morbidities. The image which is put up here, if you see, it just looks like an intraaxial tumor. If we don't pay attention to that, from where it is coming, it can be misinterpreted as an intraaxial tumor. Detailed understanding of the imaging and good clinical acumen are very, very important. Frontal osteoma with mucocele can look like an intraaxial mass. And ventriculitis per se is a really devastating condition, which has almost, in few papers, it has got more than 75% mortality and significant morbidity. Early treatment with constant vigilance is the key to success. Intraventricular antibiotics should be tried if the cell counts are not showing a declining trend. And again, look for hydrocephalus in a treated ventriculitis, which is a very, very common sequelae. Thank you.
Dr. Anirudh?
Yes, sir.
Yeah, it was a nice presentation, and you're maintaining the records.
Yes, sir.
Only two technical things I wanted to
Yes, sir.
You didn't mention about the CHF culture report. Did you
Culture
mention?
reports are negative, sir. I had written.
Negative, completely negative. Now, among so many antibiotics, what made you to use colistin in this case?
Sir, colistin, I started
Empirical?
reviewing the literature, especially the nosocomial or healthcare related, or
Yes,
where the
yes.
CSF leak is there.
Yeah.
Usually the gram-negative bacilli,
Okay.
like Acinetobacter baumannii
Acinetobacter
is very common,
very
and
common.
they don't respond to the vancomycin and ceftriaxone. So you should try colistin. Colistin has shown good results. So after reviewing the literature, then we thought of starting the colistin.
No, that's true. Even we had many brain surgeries. They
Yes, sir.
had pneumonia secondary to the Acinetobacter. At least out of 10 Acinetobacter pneumonias, at least 2 to 3 patients have developed frank meningitis.
Okay.
Meningitis, not related to the surgical techniques. It
Yeah.
is secondary to the pneumonia, Acinetobacter, nosocomial, as you said
It's
earlier.
highly virulent, and it can cause
Virulent, and
hematogenous
most
spread.
importantly, as you said earlier, the only thing is implant surgeries and shunt surgeries always we have delayed as much as possible.
Yes, sir.
Especially if it is secondary to the Acinetobacter induced pneumonia as well as meningitis. Okay, even
Yes.
implant surgeries we have delayed because out of the many cases we developed the hydrocephalus secondary to Acinetobacter meningitis. Many will end up in invariably with a hydrocephalus. That's the one technical issues I wanted to share.
I know, sir.
And anybody has reported the same similar case scenario, I mean, case reports in the journals or something like that, like the first case what you had?
No, sir. I mean, in this case, the main thing which which we were confused was it was a glioma. We are thinking
Glioma, yes.
glioma. There's a craniectomy defect, and now he has got a ventriculitis. Because
Okay.
there was a report also. So,
Yes.
which I always suspected it may not be a glioma,
May
but you
not be.
never know. It can be coincidentally, you
I know.
might have found because there is a histopath report, you can't deny it.
Yes.
So that is what made me to think, and also we gave a 4 weeks gap after this
Correct.
entire ventriculitis issue
Okay.
was sorted out, because
Okay.
he had to be, before he gets one more episode of meningitis, we thought it should be addressed again,
Okay.
because he had undergone almost
Correct.
4 times
Exactly.
EVD, external ventricular
Okay.
drainage.
Okay.
So I wanted to take a little calculated risk and go ahead, take out that whatever osteoma was there and exteriorize the frontal sinus, so that significantly you reduce the incidence of further meningitis.
Okay. Retrospectively, cranioplasty could have been delayed further little bit before the
Yes, sir.
cranioplasty should have
Could
been
have been
delayed
delayed,
little bit.
sir, but the relatives had gone through such
Okay.
a catastrophic repeated EVDs, first surgery, and radiation was also given.
Okay.
And also I found there was a component of a trephination also in him,
Okay.
because 6,
Okay.
7 years, and immediately after putting the flap, I could
Cranioplasty.
see his speech. He never
Okay.
talked,
Okay.
and immediately his speech improved.
Okay.
So
That's a good.
yeah, so that is what I did, because again taking him up for a surgery, probably relatives were not very keen.
Okay.
So because the guarded prognosis was already explained, but constantly we were behind the patient, monitoring his all the vitals. So that has helped, I felt.
Yeah, it was
And
nice presentation.
this colistin, how much did you give and how often intraventricularly you give?
Once daily, ma'am. It is according to the guidelines, 10 milligram. That is 1,25,000 international units. It comes as a different
Yeah, it comes as 1, 2, and
1
then
to 4.5 million
yeah,
units.
yeah. So you were
have
giving
to
every day.
every day we give, ma'am. I gave it for only 7, 8 days. On the 4th day itself, I can suddenly felt the cell count had come down drastically.
Yeah, it's a very
But
challenging.
the thing is, it can cause chemical meningitis.
Meningitis.
And there is no way that you can maintain a CSF trough, how much you are giving, whether it is adequate. There are a lot of guidelines need to be formulated for this type, because whatever you are giving, whether it is adequate or more, there still guidelines have to come up.
Yeah, because it's a challenging thing, and then luckily he has responded.
Yeah, yes.
Otherwise, this colistin, at least we don't know if it is, how many days you have to give, we do not know.
Yeah, exactly. Whether some
Maybe.
reports tell you have to give twice daily for 10 days, but the chemical meningitis is a very high possibility. So they tell twice you have to assess the CSF samples, morning, evening I used to do. So that the cell count is, when it is showing the decreasing trend, there are reports after the decreasing trend, you reduce it from the BD dose to OD dose. Then you can do alternate the colistin dose, because the chemical meningitis is very high.
Yeah, and then giving intraventricularly, they can develop, even other organisms also can come.
Yeah, that's what you have to do every time. You have to do, take him to OT, do very septically. You have to do all those.
And
Although
every
he
time you
had,
have to do the cell count and things like that.
yeah, repeatedly, constantly.
So Anirudh, the Maya reservoir was put up for this patient, because I think we had one similar patient referred from Mumbai, where our resident, we had to go, and because ICU people were not ready, we used to go and give injections. How was the intraventricular given through the EVD, or the reservoir was put, or how were you able to do
No,
that?
I every time we went through because he had a craniectomy defect on the left side, which was actually the ventricle of interest, which need to be tapped. But I had a challenge because there was no bone there. We can't put there. So from the right side, I used to angle it, and so that I was taking a chance so that it sits at least in the septum, piercing the septum and draws the ventricle. And with Omaya reservoir, if the CSF is very turbid, it won't flow also.
Okay.
Yeah.
Right. Anirudh,
When-
it's
Ah, sir.
quite interesting cases.
Sir.
Two things.
Thank you.
One, this type of things we have seen quite a few cases in ossifying fibromas
Sir.
of the frontal bones, ossifying fibromas. See, what happens is this ossifying fibromas, they involve diffusely.
Correct, sir.
They involve the bones, they involve the orbital roof, they involve the xiphic arch, they involve even the sphenoid bone.
Yeah.
But we have seen few cases where they localize only on the frontal bone or they localize only on the sphenoid bone. Probably this could be one of those frontal bone ossifying fibromas.
Yes,
ossifying fibromas.
Yes,
Number one. Number two, see the simple fact they have taken out the bone flap in the first surgery. There must have been when they did the craniotomy, there must have been some amount of a bone involvement. That's why they have taken out. And ultimately, what they have done, the histology.
Yes, sir.
They have taken the brain parenchyma, which is gliotic, and which has misguided them.
Exactly.
You got it. So probably it is a bony involvement. They have not got the proper histology from the bone. And since they got that grade 2 glioma, they have irradiated. You got it. That is what and there probably during that surgery they have breached the anterior cranial fossa base.
Yes, sir. Yes, sir.
They have breached it during the craniotomy.
What was surprising was they have done a CT scan also, and the CT report is also there telling it is osteoma. But what they have reported is neoplastic process need to be ruled out. If that CT scan.
No, they probably relied on the histopathology than the bone radiology.
Yes.
No, nowadays the histopathology is of utmost importance.
Yes.
Very, very important for you to further go ahead with what we are dealing with. That's why we need to have a very standard histopathological laboratory to have our, especially neurohistologists, be it neurology or neurosurgery. We need to have a very clear histological. Otherwise, you'll get confused and put the patient into trouble. A normal fellow whom you are subjecting him for whole brain irradiation.
Irradiation. Yes, sir. That's why
30 cycles.
Yeah,
it is not acceptable.
Being a bank manager, his cognitive was down, and he probably had a trephination. His speech was also, relatives used to tell he had become dull. But
and again, you have irradiated a fellow without the bone.
Exactly.
Yes. And you have created a significant brain damage, because irradiating a fellow without a bone is not a simple fact. Then all those issues. I think it's all they're confused up the whole thing in the first surgery, and they don't have the first scan when before the surgery in Pune 2016.
I have, sir. I have.
Did they have a first?
They have,
it was
sir.
there?
Yes, sir. It is there. I can.
It's there. Okay. I didn't see that.
Better.
It is there, sir. It is there.
But if the lesion was there at that time.
It is there, sir. But what had happened? Osteoma was also there. But from there, probably the mucocele.
Can you show the images? That's better.
Yeah. Can I?
If we have
screen. Yeah. Is it possible, Prasad?
It's possible.
I'm going to transfer to you.
Yeah.
Okay.
I want to show the slides. Yeah.
In the same slide you showed the pre-operative and the post-operative.
No, the first surgery, the image is
I have scans, sir. I have scans.
Pune. Yeah, before surgery.
See, this is the Pune scan, sir. 2016, you can make out also. It is written here.
No,
he was 38 that time. 2016, August. You can see, sir.
That's right.
Yeah, okay. Yeah.
Another thing what we must need to remember here and to know is this calcified ossified meningiomas.
Yes, sir.
Ossified, calcified incidental meningiomas. You see some cases when you do a scan, you see those lesions. And they have a CT.
CT is also, I have put, sir. I have put on the right side.
CT. Okay, right. So that's another possibility, that ossified calcified meningioma eroding the skull base.
But if you see the, sir, but if you see the the sagittal section of the CT scan, it is so well delineated that it's from the nasoethmoidal region going into the frontal sinus.
Exactly. Yes. This is probably ossifying fibroma of the, because you see the opposite frontal bone.
Yeah.
There is a thickening of the opposite frontal bone also. You see that.
Is it, sir?
Opposite side.
Basically, it's
Not
in the
very
midline
close.
starting in the midline going to the left side mainly.
That's right. That's right. And you see the base of the skull here.
Yes,
anterior
sir.
skull base.
Yeah, that is totally.
That's totally thickened down. Probably that is what we are dealing with. Maybe a localized ossifying fibroma.
But this tumor, what is seen in 2016, you can see there like an intraaxial. That was not there intraop. What was there was only the bony fragment.
That's right. Okay.
So that part they have removed.
That's right. Because you look at the bone window.
Sir.
The roof of the orbit.
Yes.
The roof of the orbit. If you see the bone window, the roof of the orbit on the left side.
Yes, sir.
There is hyperostosis.
Hyperostosis. Yes, sir.
There is a density of the osteoma and the bone becomes, so probably more goes in favor of that. But anyway, it's interesting. So it's an interesting case to learn a lot from these things. You understand? So good.
Thank you.
Thank you. Thank you. I think we have crossed the time.
Yeah, we have crossed the time. Thank you, Dr. Anirudh.
Thank you.
I think with the permission of the chair, can we close the session?
Yeah, thank you very much, the KNA and everybody. It was very nice. I think the Hubli team has given lot of learning experience for us. Thank you very much. And that Dr. Raghunandan and Guru Prasad went wonderful work. Thank you very much. We look forward to.
Congratulate Dr. Guru Prasad and Raghunandan. Please keep it up. And let us enlighten ourselves with our neurosciences. And it's glad.
Thank you, sir. Thank you, sir. Thank you, sir. Very wonderful cases. I think the standards of cases are at a different level. I think congratulations to the team from Hubli. I think you kept the standards very high now.
Guru Prasad, another thing that combining both neurology and neurosurgery makes a lot of interesting problems. We learn from you, you learn from us. Because neurology, neurosurgery are two faces of a coin. You got it. So we need to learn so many medical problems from you, and you need to know how we do the procedures. Because majority of these cases, you see them and refer to us for intervention. So you need to. It's a good learning, sharing, and learning. Thank you. Thank you again.
Thank you, everyone. Thank you. Good
Thank
night.
you, sir.
Good night.
I thank for helping us sorting out this Zoom issues. And we thank everyone who joined today. I think we had up to 40, we went up. I think still more people can join in future. We should encourage our graduates and colleagues so that we can have a good interaction. Thank once again Dr. Saroja, Madam, Dr. Panji, and all the presenters, Dr. Suresh, Dr. Anirudh, and Dr. Bhushan spending their valuable time actually. It's 1.5 hours, 2 hours with us. So I thank everyone who has joined today and hope we spread the message, and then in future, next month, we can have more people.
Probably, sorry, Raghu, next when September 3rd week, we will have probably IonCon. Probably we'll have to postpone to 4th week, I think. We will get back to you.
Okay, sure.
I thank Pradeep Kalolimat for coordinating the Hubli session.
I think, Pradeep, thank you.
Thank you, Pradeep. Thank you.
Yeah, thank you.
Thank you so much. Good night. Yeah.
Hi, sir. Good night, sir.
Good night. Good night.